Good day. We're still busy with HIV and PMTCT, the series, and I'm still Anna Nolte. And today we will be doing lesson 2, which focuses on HIV and PMTCT in pregnancy and labor. Okay, we have talked about the diagnosis of HIV on the previous lesson. Now the woman has now been confirmed positive, so she should start immediately on ARV or ART, the same thing, drugs during pregnancy. Now, I'm not going to talk too much about the different drugs that can be used for HIV positive women during pregnancy because they vary a lot. And in your case of a private patient, the patient usually, the medication is being prescribed by the doctor, the private obstetrician that they usually see during their pregnancy. So they arrive in your labor ward, or if there are any abnormalities during the antenatal period, they arrive there with their medication already being prescribed. If you are really interested in the different medication, you can just Google PMTCT guidelines, and then you will see all the Department of Health guidelines on how the woman should be treated if they are HIV positive during pregnancy and what medication and combination of medication should be used. There's also ARV guidelines, ART guidelines, Department of Health guidelines that you can Google. So the woman should start immediately with her ART treatment, and then she should return within 7 days after she started now with the treatment to come back for blood to be drawn for CD4 counts and viral load, so that one can creatinine results, so that one can see how serious the disease already is being. Now, all pregnant women should be encouraged to use condoms. Now, this is one of the biggest problems in private hospitals, is that women can choose whether they want to disclose their HIV status or not. So you might sit with a HIV positive patient in your antenatal ward or in labor ward without knowing that the woman is HIV positive. That's for why we are actually using the rule that we treat all pregnant women and all breastfeeding women and all laboring women as if they are HIV positive. Now, the bad thing about not disclosing the HIV status in the private hospital is because these people need a lot of education. Now, we have seen that women in the public sector gets counseling, pre-test and post-test counseling, and they get a lot of education on how to prevent infection, getting the HIV infection, how to prevent transmission to their babies, etc., whether they should give breastfeeding or not. And we're not always sure that mothers get all this information when they are private patients of private obstetricians. So we need to have an open enough relationship with these women in order to give them all the education that they need. Otherwise, one should just be very sensitive in how and discreet in how you are giving this education. Now, all pregnant women, as we're saying here, whether they're HIV or not, preferably should use condoms during pregnancy for in case they are being reinfected. Now, obviously, this depends to a very large extent on the communication, the trust relationship, etc., between the different partners. And that's why it's also very important that the partner should be involved in all this education and all these discussions, etc., specifically the condom use. And then this condom should be used in case of breastfeeding as well, because we have said that it's very important that the mother should not be reinfected when she is breastfeeding her baby. Words on antiretroviral drugs, and that's what the ARV or the ART stands for, antiretroviral ARV drugs, or antiretroviral therapy, the ART. Now, the ARV drugs during pregnancy, labor, and delivery is very important because that reduces the risk of the vertical transmission from the mother to the infant, because it reduces the viral count obviously of the HIV virus, and it also helps to prevent the CD4 count from going too low, so that the mother still have immunity and that the baby is being protected against the vertical transmission. Now, we have said that when ARV drugs are being used, it reduces the transmission to a large extent from 20 to less than 2%. And previously we have said it's 5%. So there is a little bit of a variation on the different sources and the different research and the different statistics about how much ARV drugs reduce the transmission. But I think one can say safely that it's below 5%. Now, the transmission or the risk of transmission is the lowest, and that is obviously because the viral load is the lowest if 3 antiretroviral drugs are being used together. And we talk about, you will often see the abbreviation HAART, H-A-A-R-T, which stands for highly active antiretroviral treatment. And it's usually a combination of 3 different ARV drugs that's been used together. Now, and that's one of the reasons why I'm not going into too much depth about the different drugs and how they can be used and why, etc., they should be used, because there's a lot of research ongoing on the effect of these drugs. Most of them have some negative effects, and that's why they've been changed often, etc. So the combination changes a lot. So that's why, to me, it's just important enough that you know in broad terms why ARV drugs should be used, and that usually it's a combination of the different drugs. The risk of transmission through breastfeeding, if the 3 drugs are being used, is about 0.2% per month of breastfeeding, in comparison with much higher when the mother is not using ARV drugs. Now, just a few words on nevirapine, which is also an antiretroviral drug, and it's been used, I'm sure many of you know it, it's been used in labor ward quite a lot. It's a very potent and rapidly acting drug, so it reacts immediately, it acts immediately, and therefore it's a very good drug to give during labor specifically, and specifically if when the mother is not been tested and been tested very late and hasn't been on ARV drugs, both the mother and the fetus can get nevirapine during labor, and that help both the mother and the baby, and that helps the vertical transmission. So it's absorbed orally very quickly, and it crosses the placenta very well, and therefore it also protects the baby. So a single dose is usually being given when the mothers are newly diagnosed to be HIV positive during labor. And as I've said, they haven't started with ARV treatment yet. And then the baby will also receive a dosage of nevirapine after it is been born. Then it's also very important to monitor the viral load during pregnancy, which you're also not really being involved in to a large extent, because this has also been part of what's going on in the rooms of the doctors that the patients see. But usually the ARV treatments are most effective when they are coupled with the viral load monitoring to see whether, for different reasons, to see whether these drugs are effective and whether there's good adherence, whether the mothers are really using the drugs as they should be. So if the viral loads are being done and there's no difference, the viral loads are not going down as they should, one can suspect that the mother is not adhering to the use of her drugs. And this again is something where disclosure is so important, because if the mother wants to and try and hide the fact that she's HIV positive, it's difficult for her to use a medication without anybody knowing that she's using it. Now, usually the first viral load is being done 3 months after the patient has started with ARV treatment. And then also a viral load test should be done at the time of the delivery. Usually just before the mother delivers, a viral load test should be done to determine what the viral load is, and to determine to a large extent how prone the fetus is for maternal to child transmission. Now, the breastfeeding period is also very, very important for viral suppression. So it's also important to determine the response to the ART that the mother has received during antenatal period, to make sure that it will also work for the breastfeeding period, because during breastfeeding we also want to keep the viral load as low as possible to make 100% sure that it's not the baby, or as little as possible of the virus is being transmitted to the baby. And then usually it's been done 6 months after the delivery for all women on ART, also again to see what the reaction of the ART is. Then also just a few words on opportunistic infections. What's the definition of an opportunistic infection? Now, we have said when we talked about HIV in the previous lesson that it actually affects the immune system. It invades literally the immune system and changes the immune system. So the woman's immune system is not normal functioning anymore. So we say an opportunistic infection is an infection which usually not occur in people with a normal functioning immune system. So that we get severe, repeated or chronic infections with common bacteria or uncommon organisms during these HIV-infected patients, and specifically those that are not on ARV treatment. Then the one opportunistic infection that we are very aware of during pregnancy is tuberculosis, because this is quite a frequent opportunistic infection, if I can call it like that, and specifically on patients that's not been on ARV treatment or has been positive, HIV positive for a long time before they became pregnant and hasn't been on treatment, and then developed tuberculosis during pregnancy. So it's a condition that we should be looking out for, and that we also should test the mother if possible and if necessary. So HIV infection should therefore be suspected, and we should then definitely test or try and counsel the mother so that we can test her if the mother comes with a history of severe, chronic and repeated and unusual infections, specifically now during pregnancy. Now, if we just look at the general management of a patient with HIV infection during pregnancy, now I have said previously that normally there's not a high risk of maternal to child transmission of the HIV virus during pregnancy, because if I can call it like that, the virus is, the fetus is very isolated, in inverted commas, against the virus. It's in its sac of membranes, and it's in its life core, and it's being protected from the vagina and the cervical secretions, and the placenta plays a little bit of a role, in the sense that at least antibodies come from the mother to the fetus over the placenta. We will only get HIV maternal to child transmission during pregnancy when this closed system, what I was talking about just now, is being disturbed. When there's, for example, in placenta abruptia, when a part of the placenta goes loose, or in an amniocentesis where the placenta has been injured or the baby has been injured, or cases where the viral load of the mother is really very high and the virus can then come from through the placenta. But normally our management of the patient during pregnancy, of a HIV pregnant patient, positive pregnant patient, is basically just very good antenatal treatment. So we make sure that the mother gets a good balanced diet, and specifically to help prevent weight loss. Now, this is not always possible in the case of low-income groups, but one should try and give as much as possible education so that they know. To treat and also to diagnose opportunistic infections if they do occur, to monitor the clinical and the immunological progress of the HIV infection, and this is usually being done by doing CD4 counts and viral load counts at regular stages. To give the mother ARV drugs, to give lots of emotional, social, and financial support if necessary, and the financial support specifically in the cases where the mother is going to not breastfeed the baby. So in many of these cases, social workers should be involved in the management and the treatment of these patients. Prevent. Now, these last three bullets are, as I've said previously, very important to give the mother the correct education. Now, the education, as we've said, is education that all mothers should receive, but specifically HIV positive mothers, to prevent the spread of HIV to others and to herself, to get continuously exposed to the HIV infections, so to prevent reinfection and to prevent new infection. And then specifically, lots of education on infant feeding. Now, again, as I've said previously, what is important for us is disclosure, that the mother should disclose her HIV status for us to us in order to give her the correct information regarding infant feeding. When we will come in the next lesson to infant feeding and why breastfeeding or not breastfeeding is very important, and we will talk a little bit about that there. Now, the vertical transmission during pregnancy, as I've said, is not doesn't happen that often, but it happens in the following cases: when the mother becomes infected with HIV during pregnancy, because we have said that then the viral loads are specifically very high. When the mother is in an advanced stage of infection and she hasn't got any ARV treatment before pregnancy and even now during pregnancy, so we again sit with very high viral loads. So the higher the viral loads, the bigger the chances of vertical transmission between the mother and the fetus. Then also mothers who are infected with syphilis, we have said in the first lesson, that's becoming very important, because when there's syphilis, there's also, the mother is having syphilis, she becomes much easier infected with HIV during pregnancy. And then, as we've said, when she becomes infected during pregnancy, there we have higher viral loads. Mothers who are undernourished, their immune system is being compromised in general as it is already, and now it's even worse. Mothers who do not receive ARV prophylaxis, because as we've said, their viral loads will be just much higher. Women with the antepartum hemorrhage, this is important specifically in both cases, placenta previa as well as placenta abruptia, where parts of the placenta are going loose and there's bleeding, and the fetus comes in contact with the blood through the placenta or in the uterus, and that also causes the possibility of HIV infection. And women who have an amniocentesis, if the placenta or the fetus is being injured and causes a break in the fetal skin where the virus can be transmitted through. When we come to the question, which pregnancy complications are commoner in women who are HIV positive, I think we have talked about the first group of infections. They are the opportunistic infections that we have talked about, and specifically we've said the pulmonary tuberculosis is the one that we are quite at the lookout for, and then also other sexually transmitted diseases, because that we've said also increase the viral load of HIV, and then also urinary tract infection. The risk of stillbirth is doubled, and it often is been associated with chorioamnionitis. Chorioamnionitis is quite a common complication that we find in HIV positive women during pregnancy. It means it's an infection of the chorio and the amnion, and that has obviously an effect on the fetus as well. Especially in the undernourished and underweight mothers, intrauterine growth restriction might be a problem. A placenta abruptio, anemia is quite a common problem under HIV positive women who are not well controlled, who are not adhering well to their ARVs, and where the condition is quite advanced. And then we also preterm labor and premature rupture of membranes are quite often happening, and I think that also is to a large extent due to the chorioamnionitis. Then specific PMTCT transmission during labor and delivery. When during labor and delivery, and in what cases does transmission take place? Now again, like we've said with pregnancy, the higher the viral load of the mother is, the higher the possibility of transmission. But then also all the following factors are playing a role. Now, the thing that we need to remember during labor and delivery is that the infant is being exposed now to cervical and vaginal secretions, and cervical and vaginal secretions are very, I almost want to use the word rich in HIV viruses, and the fetus has to pass through this cervical and vaginal secretions when it's been born, as well as maternal blood, specifically in the case of episiotomies, and that all may cause HIV transmission to the baby. Ruptured, now the different conditions or the different factors that influence transmission during labor specifically is ruptured membranes, because obviously when the membranes are ruptured, the infant are now is now being exposed to the cervical secretions and blood. And the longer this period of ruptured membranes, and every time that the vaginal examination is being done, some of these cervical secretions are being taken to the uterus, and that exposes the infant to this infection. So the longer the membranes were ruptured, the higher the possibility of the vertical transmission. And specifically more so if the woman is not on ARV prophylaxis or treatment. And then membranes, we use the principle, as I've said previously, that we treat all mothers as if they are HIV positive, specifically because all mothers are not being disclosed the condition, and also all mothers haven't gone for testing. So mothers might be positive and they have refused to be tested. So there might be positive HIV positive mothers without us knowing about that. So membranes should not be artificially ruptured, specifically because of this possibility of PMTCT with the vertical transmission from the mother. And there is lots of research that also has shown that there's not really any advantages in rupturing membranes artificially in labor. It's not really speeding up the progress of labor. Then episiotomy should only really be done if there's a good indication for them, because obviously when an episiotomy is being done, there's blood and the baby has to pass through this blood, and then if there's a break in his skin or in his mucous membranes in his mouth, etc., it's a good place for entering of the HIV virus. Then in long labors, the longer the labor, and specifically in prolonged labor, there's also a greater risk of transmission than in short labors. And again, the big problem here is repetitive vaginal examinations. And this specifically more so in mothers without ARV treatment or prophylaxis. Transmission is also higher in preterm infants than in term infants because the term infants to a large extent is a little bit being protected by antibodies from the mother. But most of the antibodies that go through the placenta are going through the placenta more the last weeks of pregnancy. So the preterm infant will then lose out on these antibodies from the mother. And that's why transmission to the preterm baby is more than a term baby. Vacuum extractions, usually when vacuum extractions being done, whether it's a silicone cup or a metal cup, it doesn't matter. There's always some small abrasions on the fetal scalp. So there's small breaks in the fetal skin on the scalp, and that obviously, as the fetus moves now through the cervix and the vaginal and maternal blood, etc., it makes the risk of transmission so much bigger. Now, the suctioning of the baby is one other very important thing. I think we all overdo suctioning of infants when they're being born. If it's not necessary that the baby needs to be resuscitated, it's also not necessary to really suck the baby. One can, with a little piece of gauze over your finger, rub all the unnecessary extra mucus from the baby's mouth. So it's only really in the case of resuscitation where there's a lot of mucus, meconium stained liquor, etc., where we really need to suction. And even then, one should suction very carefully not to damage the mucous membranes and then obviously increase the risk of transmission. Then infants should be well dried after the birth to remove all the maternal blood and vernix as quickly as possible, and liquor, because this is usually where the viruses might also be after the fetus have now been passed through the birth channel and there's been contaminated with maternal blood and vaginal secretions, etc. So it's not necessary to immediately bath the baby, but to at least remove as much as possible of this from the baby's body. So to dry him and then remove the towel and put him in a clean towel. Delayed cord clamping is very acceptable. There's no reason why the cord should be clamped immediately in the case of a HIV positive mother, because there's not really HIV viruses going through the cord, so that's not going to improve or make the transmission of vertical transmission higher. So we can practice delayed cord clamping in the case of HIV positive mother. Just a few words on ARV or ART treatment and viral load during labor. Now, all pregnant women should continue on their ARVs when they go into labor. So, and that's where I say that usually in the case of private hospitals, the patients arrive at hospital with already their ARV or ART treatment already been prescribed. Now, if they are newly diagnosed or a known HIV patient and they are not on ART, that is when one should give the mother immediate dosage of nevirapine. And then afterwards, ART treatment should be prescribed to her. That's also obviously if she gives permission to it and if she wants it to be given to her. But nevirapine is usually given to the mother, and then it will also be given to the baby after the birth of the baby. And then we said that it's preferable that all women should have a viral load test done just before delivery so that one can see what the results are, how many viruses are there, how prone is the mother for vertical transmission to the baby. The viral load result should mostly be known so that one can also know whether the infant should get nevirapine or not. But if it's not known, then the baby should get nevirapine anyway. And the results of the viral load must be checked at the 3 to 6 day postnatal period to make sure that the management of the mother and the infant has been adjusted according to the viral load, and her ARV drugs, etc., being adjusted to that. Now we will talk about the care to the baby to a very large extent in the next lesson, so I'm not going to say too much here. We have said that we will use the PCR test to identify the HIV positive babies, and so I'm not going, as I'm saying, to say too much more about this here. We will talk about that in the next lesson. And that brings us then to the end of this lesson. And again, you have to do your quiz to be able to continue to the next lesson. And I hope that you've learned something new.